We'll go ahead and just get started with our introductions. It'll just take a few minutes here. This is our first session of our second project SCOPE, and SCOPE stands for Supporting Children of the Opioid Epidemic. And so I'd like to just do some introductions. If you're one of the SPOKE participants, if you're a participant today, then please enter your name and your role and where you're joining us from into the chat. And that way we can get an idea of who's joining us, who our audience is. I'll start by introducing myself. My name is Sarah Clancy, and I work at the Institute for Human Development here at Northern Arizona University. I'm an occupational therapist by training, and I work in early intervention and with other programs that are supporting children and their development. I also am endorsed in infant mental health. So that's one of my passions here. So we've wanted to bring Project SCOPE to Arizona and to especially support families with children who have substance exposure, and just kind of look at it through the lens of infant mental health and the relationships as well. So I'd like to pass on the mic, I guess, to Nicole Rambo so she can introduce herself too.
Hi, good morning. I'm an occupational therapist with the Institute of Human Development as well at NAU. I'm actually here though as part of my LEND training. LEND stands for Leadership and Education in Neurodevelopmental Disabilities. And it is hosted by the University of Arizona in Arizona. So I'm here just kind of helping out with all sorts of background stuff too as a LEND training. Thank you.
Great. Thanks, Nicole. And another of our hub members, or one of our organizing partners, is Jillian Schultz. Would you like to go next?
Sure. I'm Jill Schultz. I'm the Dependency Program Manager at Coconino County Juvenile Court. And so I oversee the court processes and family support programs that we offer for families that are involved with the Department of Child Safety.
Thanks, Jill, for being here. We're so happy to have you
Thanks.
for this iteration. And Lizette, can you introduce yourself as well? You're muted. Sorry.
I think we should all wear t-shirts that say you're muted.
Yes.
I've heard the quality of my audio is not good, so I'm getting a headset for the future. But just to let you know, I'm Lizette. I'm a child development specialist at North Country with a program called Healthy Steps. And I'm here to learn and support the program in any way I can.
Great. Thanks, Lizette. And as you're all joining, just a reminder to put your roles and where you're joining us from into the chat, and that would be really helpful just to get to know everybody. Just a short introduction into Project SCOPE. This is a national training initiative that was designed by Ohio State, the Ohio State University, and the University of Cincinnati, along with the University of Wyoming and the Institute for Disabilities. This is a program that was designed to reach those of us who work directly with children, and not just the program managers who often get the training. So this is open to anybody, whether you are an early child care caregiver at a center, or a foster parent, or an early intervention therapist, mental health therapist, adoptive parents, anybody who is directly involved with children who've been affected by substance use disorder. So we're really just trying to create communities of practice and support for people who are in the lives of these children. And we're using a special model called the ECHO model, and maybe some of you are familiar with it. There's lots of different trainings now that have been using the ECHO model, but it's ECHO stands for the Extension of Community Health Outcomes. And this is a model that is designed also to provide free continuing education using instructional or didactic trainings and case study reflection. And it's all built around using Zoom to connect subject matter experts to community members. So we're really excited to be able to offer our second version of this training, and we're extremely excited to have Dr. Sydney Rice joining us for the first presentation today. So I'd like to introduce her. She is joining us as a professor of pediatrics at the University of Arizona. She holds a bachelor's degree from Stanford University, a doctoral degree in medicine from the University of Arizona, and a master's degree in health evaluation sciences from the University of Virginia. She completed a developmental behavioral fellowship at the University of Virginia and is an active clinician caring for children with disabilities, including seeing children with autism, spina bifida, cerebral palsy, brain injury, preterm birth, and early drug exposure. She participates in multiple research teams investigating each of these conditions, and she also joins us once a month here at the Institute for Human Development at our interdisciplinary evaluation clinics. So Dr. Rice is, we're just really excited to have her, and especially have her today with us to speak about neonatal abstinence syndrome and the NICU, and what that means for a lot of our little ones. So with that, Dr. Rice, I'm going to pass the presentation over to you. So thank you.
Thanks, Sarah and Nicole, for having me. I really enjoy doing this. And thank you all for putting your interest and background in the chat, because I'm really impressed by how many foster parents are here. That's awesome. So we're going to talk about neonatal abstinence syndrome. But I first wanted to start with a background of the NICU experience. I don't know how many people have actually been to a NICU, but it is, for any family, a very frightening experience. So look at this isolate, how we interact with babies. It's not normal. This is not a normal way for a baby to be. And so we reach through plastic, and often babies don't see us coming. In this kind of situation with all of this equipment, parents frequently feel disenfranchised and really afraid of their own children. Many parents who have had children in the NICU are traumatized forever. It's a very challenging experience to go through. And then we're going to layer on top of that the experience of a family who's using drugs and is feeling stigmatized already, and then their baby is put in this kind of situation. So just if you've never been to a NICU, this is probably not the time to go, because they won't let you in with COVID. But at some point in the future, if you've never been to a NICU, it's a good thing. Or if you are caring for somebody, a family, and you have the opportunity to go visit the NICU, it's a really good thing to see, so that you get a sense of what parents have been through. So neonatal abstinence syndrome is a description, a physical description, a biological description of withdrawal from certain drugs, most frequently opioids, but I'm going to talk about other drugs as well. I hear a lot of people getting confused about what opioids actually are. Opioids are the drugs that you would have heard about would be codeine, hydrocodone, Percocet, Oxycontin, heroin, fentanyl. Those are all opioids, but I'm going to give you a list of other drugs that also cause withdrawal that are not considered opioids. There is a reason to kind of make that distinction. Withdrawal from any drug is very uncomfortable for the baby and for the caregiver. It's a challenging situation on both sides. Neonatal abstinence syndrome is different. Sometimes there's confusion between NAS and a teratogen. A teratogen is when a drug was ingested during pregnancy that caused a change. We have, for example, some of our seizure medications. So, women are prescribed seizure medications. Some of those medications can actually cause brain injury, brain damage, all kinds of different problems. But women might not recognize, because it was prescribed medication, that there's a potential for that to happen. Another one is alcohol, where we can see poor growth of the brain in general, poor growth of the baby, and brain malformations associated with alcohol ingestion. Though that's called a teratogen, which is different from withdrawal, which is neonatal abstinence. So these are some examples of non-opioids: alcohol, barbiturates, cocaine, and you can see, I'm actually sorry, I'm moving the pictures because I can't see. For each of these, there's an expected onset of symptoms and then a duration of symptoms. I'm always amazed by the alcohol, how long the effect of alcohol exposure can last in babies. Barbiturates, the same thing, months. And cocaine is generally pretty quick. It's not great, but you get done with it fairly quickly. Nicotine and SSRIs. If you have questions, please feel free to stop me. And I don't think I can see the chat, but if Sarah, Nicole, you want to stop me if there's a question.
Yeah, we'll let you know if anything's in there. Thanks.
Mm-hmm. So what does NAS look like? Babies are shaky. They might have a seizure. We don't see that a lot. What we see is overactive reflexes. They're just kind of, when we test the reflexes, if you're probably all familiar with somebody tapping your knee. And for babies, it's an over-exaggerated reflex. And so we can see it physically on our neuro exam. And in general, they're very tight. They might arch a lot. They're just much tighter than you would expect a newborn to be. They are very fussy. And one of the challenges is there's a very typical cry from a baby who's withdrawing, and it's extremely high pitched. And if you are a parent who doesn't have a lot of resources and are struggling, that cry is horrible. It's horrible for anyone, but this is one of the reasons why babies who are withdrawing and go home with their parents who are struggling might be abused, because it's a really terrible cry. Difficulty with feeding and sucking, coordinating that oral motor coordination. Often we see them panting and breathing really fast. Sometimes they'll have fevers, get very sweaty. Lots of yawning is a very typical thing. And then falling asleep, but not sleeping for very long. So kind of disrupted sleep. Diarrhea or vomiting, and then just sneezing and having a kind of stuffed up nose. Those are the classic signs of NAS. Our big worry is that because this is something we have to get through, the withdrawal piece. So it's hard, and I'm going to talk about how we grade getting through the withdrawal. But one of the big issues that comes up is that babies who are exposed in utero to drugs have intergenerational effects. So if you look at the mom in the middle here, if she is taking drugs, the baby's clearly affected, but the gametes, so in the sperm for the boys and the ova for girls, are already present in the neonate, in the fetus in utero. So mom's use of drugs, of anything, affects her child, but also affects her grandchild. Now, conceptually, I find that almost, actually quite frightening, that these intergenerational effects, it's your grandmother's health and wellness and choices that affects your health today. So this is something we're looking now at how scored. This is a scale that we used to use more. We're shifting away from it, but you will probably hear about it. It's called the Finnegan scale. And you get scores, just all of the different things that I talked about that are part of the diagnosis of NAS. This is what you get, numbers and points for each of this. And then what happens is in the NICU, there will be this kind of chart that says start Finnegan scoring. We know that there's been exposure. Here's the Finnegans. And if you have 2 consecutive scores of greater than 12, you move this way. Does the mother taking opioids? Yes or no? And what it's doing is helping us decide what kind of medications we're going to use at what dose for this baby to help wean them off of drugs. And so this is something that we used for quite a long time, which we are using less now. And I'll show you now what we use. Actually, here's, when we use the different medications, if you saw back here, if they're on opioids, that's one of the reasons that we need, in this pathway, we need to distinguish between an opioid and a non-opioid, is because we're going to use morphine, which is an opioid, if you're withdrawing from opioids, and we're going to use phenobarbital if it's a non-opioid. And so here are our options, and here is the way that we do this. What's happened is that we're moving away from this very medicalized model, and we're moving to this much simpler model, which is called Eat, Sleep, and Console, ESC. And this is the care tool where we look really at what does a baby, what is an infant, what's their job? Well, their job is to eat, their job is to sleep, and their job is to be able to be consoled when they need something. And so this is a different tool. This is now used in most NICUs, this newer model. And it really is a much more practical model of present or absent. It's just, is it there? Is this problem there or not there? And then has a plan of care that tells us what to do. If there's a lot of challenges going on, baby can't eat, baby can't sleep, baby can't console, is there a formal parent caregiver huddle, and whether or not that happened. And in that huddle, what's going to happen is let's problem solve to try to figure out what we can do better. And sometimes it's giving parents a break. Sometimes it's doing a different way of holding or cuddling. Sometimes it's changing the way that you feed. And then sometimes when things are really tough, we'll do the full care team huddle. So the parent caregiver, it would be usually the NICU nurse and the parent. And then the full team is you got everybody, the therapists, the doctors, everybody who's involved to see what we need to do. So this is what it's called, is Eat, Sleep, and Console. And this program is available in almost every NICU if the parent is identified as using drugs and it enrolls in this program before the baby's born. So knowing what's going to happen. And what's going to happen is that instead of you going down those pathways of using medications, the family is going to need to room in the unit. And most NICUs now have separate kind of living quarters, like mini apartments, where the family stays there. And they have to agree to this. Because they need to be, it's just like when you have a baby, you need to be present. So they room in with the baby. They do a lot of skin to skin, and they're swaddling, swinging, and soothing. They call them the S's, the 4 S's, and using some kind of sound. What happens is that the baby and the family are together in a rooming in situation, and the nurse comes in just like as she would, the baby's still in the NICU, but offers guidance and support and communicates, and it really becomes a team effort to help care for the baby. Within this model, and the reason for the model is that we've really tried very hard to move away from blaming and shaming. That that we are going to help you get through this, and we recognize that this is a challenge, and it's a challenge for all of us, but we're going to help. But again, not every baby has this opportunity because you're only enrolled in this program if you're identified before giving birth. So what do we do with it? One of the big goals is to reduce stigma. As expected, many women don't disclose their drug use because they know that they're going to be judged. And so there's all kinds of campaigns. I'm sure you're very aware of all kinds of supports in the community talking about addiction as a disease that can be treated, and that women and families can be supported. So when women are enrolled, they're in this program, they're supported as well, and usually they're engaged in some kind of addiction management program. So in order, again, to enroll in this program, you need to self-disclose, and the teams across the country in NICUs have been trained in this, and to be non-judgmental, to be collaborative, to be supportive. And there's a discussion at the beginning when the mother or family is enrolled about, we all have the same goal. We want the baby to be as healthy as possible, and we know that they're likely going to withdraw, but we want to make it as easy as we can for everyone. And parents, when they're living in these little apartments, are encouraged to have grandparents come, have other people engaged and learning during the NICU process. So these are some of the tools that the families are taught, is to always provide, just this is at the beginning particularly, to have 2-person care, because these babies, they're different. They're very different from a neurotypical baby who's not been exposed. They're stiff, they're screaming, they're fussy, and this is a hard thing to deal with if you're on your own. So having 2 people, one to help and one to comfort, is really helpful. This is the other thing that we do is I showed that picture of the NICU, and it is really common, unfortunately, in the NICU, is that we need to evaluate babies, we need to check them. we try not to wake them up, but it's kind of, I think about yourself. If somebody kind of, you're sound asleep and somebody, these arms come out of nowhere to touch you or move you, that is a frightening experience. And so we try as much as we can to wake the baby as you would like to be wakened. So speak to them first, hold, use containment, so that's the picture on the right, is kind of containing them, not just kind of tapping them, but really containing, and then provide a gentle touch. Then after families go home, they get the parents or the adults, whoever's involved, get long-term monitoring and support. So is that for drug use? Is that they we're going to put in supports for babysitting or other help? And then we have the babies come back every few months to look at their development. And these are the different areas of development that are often affected: their behavior, their cognition, their motor skills, speech and language skills. And we worry about vision, and I should have hearing on here too. We will retest hearing and vision to make sure that there's no issues there, because issues there are definitely going to affect their ability for development. And that's it.
Great, thank you, Dr. Rice.
Question.
Yeah.
And I apologize if this was addressed earlier, but if a newborn is born exposed and goes through withdrawal, do they automatically receive the NAS diagnosis, or is it based on like certain criteria that they have to meet?
If the neonatologist will give that diagnosis if they recognize that there's withdrawal. Now, if it's not identified, then they won't receive the diagnosis. But if the NICU team sees withdrawal, they are going to document it, and NAS will be one of the diagnoses.
Thank you.
Good question. Lisa.
Yes, I just had a quick question about, I know you mentioned that these are for babies where the parents disclose and sign up for the program. So what about the babies that are not in that situation? What kind of services do they get?
Right. So if there's no disclosure and the baby, then typically what would happen if the baby's born at term, they'd go to a normal newborn nursery, and then the nurses or the people there would start to recognize the withdrawal symptoms. So then what's going to happen is to have that discussion with the family, try to figure out what the exposure was. DCS is usually called. And I think, I think all of us think somewhat of DCS as being punitive, but in this situation, DCS tries to put in the right supports to support the family. And there'll be an evaluation of the parents' abilities to care for the child safely. So in that situation, without disclosure, DCS is usually stepping in.
Okay, got it. Thank you.
Mm-hmm. Yes, Rebecca.
Hi, Rebecca. Go ahead.
Hi. In the new model that's being transitioned to, the ESC, is that avoiding drugs? So the idea is you're comforting the baby and you're not having to add in those additional drugs to go through.
That's a great question, and I'm sorry that I didn't explain that better. Yes, really, most of the babies who go through the Eat, Sleep, and Console do not receive medications. It's remarkable how well the program works.
That's amazing. I went through the process with adopted children once about 12 years ago, and another time 2 years ago. And in those 10 years, there were huge, wonderful changes. And this is another huge step.
I really love it because the phenobarbital particularly, I really don't like phenobarbital for newborns. It makes them sleepy and kind of drugged up and slower. Morphine does too, but phenobarbital is actually worse developmentally. So it's really, I completely agree. I'm really heartened by how our direction.
That's great.
Yeah, go ahead, Nicole.
I had two questions. One was, how do we really know when the withdrawal process is finished or complete? Is that when we don't see any signs of withdrawal?
Yes, from the eat, sleep, and console, can they eat, sleep, and console? It's really fairly simple. On the Finnegan score, you have to use a scale. And the duration of that is going to be based on what the drug was that was ingested by mom. So that was that table that I had earlier. It really depends. So sometimes it's pretty quick, like cocaine is pretty quick, and then other drugs are much longer.
And then for the first few months at home or after discharge from the NICU, is that sleep console model still appropriate to to keep following?
Absolutely. I mean, I kind of think it's good parenting. It's just, if your baby can eat, sleep, poop, and you can calm them, that you're in a great situation. That's just kind of I think it's just good newborn care.
I have one more question. So does it happen? I'm sure it happens, but like, for example, the one I have is not really showing any like impacts right now. Like he's very, knock on wood, hopefully I'm not gonna jinx myself, but like he's very chill and like not really having any issues behaviorally or anything like that. Does that also happen like fairly regularly, or is it possible that like he didn't really have like a lot of exposure maybe?
That's a great question. So for different medications or different drugs, it often depends duration of exposure and then timing, which trimester the exposure was, and then the drug itself. Honestly, with opioids, it's really it's a hard withdrawal, but I see less developmental problems with opioids than with other medications. And this is just anecdotal, so please, it's very hard to do research on this to look at outcomes because you can't get a good, nobody, if you're doing a lot of drugs, you probably don't remember when or how much, you just did them. And so I will say that in general, the most challenging children who I see developmentally after exposure are the ones who've been exposed to meth. It's horrible. Much more cognitive and behavioral stuff. I see less with the opioids. Although, I don't want to say that, opioids are good, but developmentally, it's horrible in the beginning, but it doesn't seem to be quite as bad developmentally. So no, I think that it's great that your child's doing well. We do really monitor ongoing, as they go into school and things like that. But I would just take that as, at least a win for now. That's awesome.
That's great questions. It's so nice to have a group of foster parents and other professionals here to kind of bring in those real experience questions. So thank you all for sharing that. Are there any more for Dr. Rice? Or any comments or experiences you want to share? Well, great. Well, thank you, Dr. Rice. We always love having your expertise shared with us.